This is a Chronicle podcast, bringing you ideas in the service of medicine.
Greetings and welcome to Shear Listening Pleasure with your host, me, Neil Shear. I'm a recently retired academic dermatologist. Over my career, I have been inspired by my many colleagues and trainees who are dedicated to helping people with major life-altering skin conditions. Some people don't recognize dermatology as a real medical specialty. Oh, but is it ever? From the many stories of patients and providers, I hope we can inspire others. We will travel across Canada to delve into inspirational contributions to improve the quality of life of others. Very few specialties have as many diverse diseases as dermatology. So without any gory photos, just friendly chats, we will take you into a world behind the scenes, a world of caring, compassion, and inspiration. I'm very pleased to have Dr. Marissa Joseph, who is a dermatologist in Toronto and a good friend. We've worked together for many years and continue to do so. And I'm very, very pleased that she agreed to be part of this podcast collection for many reasons, besides Marissa and me just telling you this, how amazing she is. But I think I'd like to go back to, if I can, Marissa, to get back into like Nova Scotia. And I don't know that dermatology was necessarily what you were aiming for when you were moving forward in medicine, or was it?
It's a good question. When I think way back, I wanted to be a surgeon and was quite set on that. And for interest, I actually wanted to be a cardiovascular surgeon. I don't know why. In some ways, I think that would have been a fit for me, but in a lot of ways, probably not. And in your very nice intro, you forgot to mention that you're a very big mentor to me. And the mentorship relationship. And why that's relevant is mentorship is so important to guide where you end up going. There was a cardiovascular surgeon, a pediatric cardiovascular surgeon in Halifax when I was going through my first year of med school. And I really liked that person. And then they up and moved to Alberta. And so there goes the mentorship. And then there goes my future trajectory into cardiovascular surgery. But that's kind of where I started. And then I kind of knew that I wanted to do pediatrics. Not sure why, but I just knew that's what I sort of gravitated towards. Then again, in mentorship, I guess I like to do things in the people I liked. And I liked the way that they approached things or the way they presented medicine and interacted as a teacher. And so there was a neonatologist I really liked. Then I thought I might want to be a neonatologist. And again, that would have fit me in a lot of ways and probably not fit me in others. And then in the end, I was really aiming towards hematology oncology, but pediatrics nonetheless. And so that took me on a journey to pediatrics residency. Then I met another mentor, someone I really liked, named Brenda Morose. And I did a pediatrics elective in Montreal, intending to do rheumatology, but ended up that rheumatology wasn't available. So they stuck me in derm. When I did that rotation with Dr. Morose, she was just this force to be reckoned with. She was an adult dermatologist and a pediatric dermatologist, and she was just so wonderful. She was not warm and fuzzy, but she just had this way of communicating, and she had this enthusiasm about pediatric dermatology. And then in her sort of way, she told me, you should be a dermatologist. And I hadn't really thought about it before, but I really liked her. But in the end, I sort of hitched my wagon to pediatrics. And then there was a journey from there.
You know, it really makes you think when you see people who seem to be born and then say, I want to be a dermatologist, and then they follow that line as if it's real to do each stage. So many of the stories are very much like yours. It's not planned, it's not predicted, but besides a lot of curiosity about what you can do and what you can contribute, you sort of learn, at least I think I did, that whatever stage I finished, it could be the 8th grade, and then I had to go to the 9th grade. You thought you were full of yourself, and then you get in the next level and you don't have any idea what's going on. And you can do fellowship after fellowship. When you leave the Hospital for Sick Children pediatric program and then go into dermatology, as I did from internal medicine into dermatology, you think you know something. And then you get there and you go, I don't know anything. It's like so humbling, but you have to just keep paddling. You just keep paddling. And you did all that. And that transition, I have to say, I was very fortunate in terms of, as you mentioned, mentoring. When people went through that double specialty, which you really can't do very much anymore, I kept saying, you're going to have to let pediatrics go for a while. You're going to have to let internal medicine go. You can't keep all these balls in the air. And frankly, a lot of them are contradictory. What you're learning in one specialty is actually wrong in yours. So it is challenging, but you made that transition. It's painful, isn't it? And maybe that's not the right word. Challenging.
It was painful. Yeah, I think when people ask me honestly, it's easy to look back 12 years later, 14 years later and say, well, it was easy, but it wasn't. And talk about not knowing anything. I went from a different type of knowledge, chest compressions at 2 a.m. to having to study all the time. And I don't even know that I knew how to study well. It was a very different way of reading. And then as an aside, and I tell all of the trainees this, when I started in derm, it was like a different language. And language is so important to understand dermatology, the descriptions, the morphology. But the acronyms, I used to, some of my cohort, they remember I carried this little notebook. I kept it small because I was so embarrassed. And people would say acronyms, and I got tired of saying, what's that? What's EED? What's that? So I would just make a little note. And then I would Google after clinic, and I would get like all sorts of different things, like the engineers of America, But then I realized I evolved from that shame to it's okay not to know stuff. And I think that transition helps me even now because there is a lot of imposter syndrome, even at every level that I go to. I transitioned at some point to, wow, I really don't know anything. That I know something about that. And I really don't know about the next thing. And so I think that comfort with not knowing something, but wanting to figure it out has helped me a lot too.
I just wanted to make a comment about when people say, "Oh, ask anything," and you're afraid to do it. You could have just said WTA. What's that acronym? They'd say, WTA. What do you mean? Well, what's that acronym? Oh, and next time you just go WTA. After a while, they go, "Okay, we'll spell these out each time. We'll let you go." I never thought of it before. We have to get that into the lexicon. I had an experience with a very prominent dermatologist in pharmacology in the United States and met him at a meeting in Toronto and ended up getting a lot of guidance from him. But the one thing, it was a very short story that really impacted me, was when he left dermatology to go do basic pharmacology in a different university. And the guy he was working with said, "I want you to learn about P450s. There wasn't really much known at the time, in fairness. Go to the library, read about it, and come back in 2 weeks." So he did that. And each time he came back, his boss said, "So do you understand it?" He said, "Yes, I do." So after the third time that he came back, his boss said, "Do you understand it?" He said, "No, I'm confused." And he said, "Now we can start." And I think part of medical training is, and the students want this, certainty. This is how you treat this. And if you go to a new hospital and they treat it differently, you go, "Oh no, that's wrong." And you go, "No, it's not." And you still don't get it because on an exam, you don't get a choice of pick which 3 of the 5 you think are appropriate answers. But it's interesting, when you get into that very uncomfortable position of not knowing stuff and going, "I'm confused." And then you look and you find out there's things you're discovering. So what areas are really, giving you the energy to keep going and growing? And you're working at many hospitals and, which is great in Toronto because you actually do get experience outside your home base and you get to see how things are done and things have changed a lot. So, what are you working on now and what are you transitioning into?
Well, there's a lot of things, a lot of balls in the air. I guess when I think about dermatology and diagnosis, after some time, you get comfortable with making some diagnoses. There are the, interesting cases that come that have quite the differential, and you sort of have to figure that out. But a lot of the time you sort of get comfortable with the morphology, and you might guess and, kind of educated guess and get it right. But then there's the therapeutics. And so the immunology part of dermatology, there were, a few biologics when I first started treating patients independently, but now there are so many pathways and so many mechanisms and so many diseases that clinically don't look the same. But when you look at the pathophysiology, they're quite similar. So you can almost repackage old medications or oldish medications and use them for new indications. It's almost difficult to even keep up with a lot of that stuff. So I find that very interesting, and that's sort of one of my interests. I think the other thing that has sort of become more apparent to me, and I think that's across medicine, is how we provide care and some of the inequities in how we provide care, and also the patient's experience with how we provide care in dermatology. So the other big sphere, I guess, that I've sort of dropped into is looking at EDI work and dermatology, and what's the future of dermatology in being inclusive and treating everyone, particularly patients who have been underrepresented over time in terms of description of their diseases and clinical trials, and how we educate non-dermatologists to recognize disease. So I think where I sit comfortably in my dermatology career, what really makes me interested and engaged and want to find new ideas and learn, is probably in those two big spaces.
That's interesting. They are very big now in terms of, two big spaces now. Things that they've always been issues, but they've sort of been managed in a very local, restrictive environment. And now it's everywhere. And I think certainly the underserviced inclusivity in many ways is, despite the American perspective, us having, no healthcare or free healthcare for everybody. And I say, well, you can get healthcare. You just may not be able to get the drugs that you need, but you can get the healthcare. You need this drug. Oh, good. How do I get it? Well, you can't. There's so many things. So how do you manage, and even in your educational aspects, how do you manage these things? How do you manage inclusivity, and just even picking one type 2, diseases like atopic dermatitis, and how does it impact your practice and trying to keep up with it and teach with it and all that? I mean, where does it fit into your day?
It's sort of funny because sometimes you just know something in your gut and you feel that there's an issue, and there's a difference between that and scholarly activity. And so, I think for a long time, I know there's an issue. There are certain things that I notice in my teaching, in my practice patterns, particularly with non-dermatologists. And then it's sort of, but how do you prove it? How do you talk about disproportionality? How does dermatology fit in to a conversation where, big things, mortality in childbirth and disproportionality, or end-stage renal disease and diabetes in Black patients? There are these big, heavy medical conversations that are happening. And it's sort of like, where does dermatology fit in? Why is that important? How do you lend your voice to that? And I think where I've sort of evolved to try to approach it is to try to have some scholarly activity and just answer a question. One recent example was thinking about the COVID-19 pandemic. So we have a situation where Black patients are 10% of the population in the GTA, but over 20% of the patients who are infected. You have South Asian patients, same thing, maybe just under 10% of the GTA, but yet over 20% affected. And then from the dermatology perspective, you sort of say, okay, well, the more people with brown skin are affected by COVID-19, but then you start to look at all the emails being passed around about what the eruptions look like associated with COVID-19, and you're not seeing any pictures of Black people, or brown people, or Asian people. And so you sort of say, well, is it that they don't get rashes with COVID-19, or is it just similar to other things in medicine? We're not reflecting it. So then you sort of team up with a medical student, look at the literature, and then you publish something. And then you hope that someone who has access to larger databases and different things will do a prospective sort of review. But it's marrying what you think to be true with that scholarly activity and trying to lend dermatology as a voice at the table in lots of these aspects in medicine that we're beginning to highlight some of these inequalities.
Yeah, I appreciate what you said. It's very well stated. And, we can get people, if you will, into the door, but of course, with all the virtual consults, are you doing many virtual consults?
I was. It's a bit of a mix because my practice is skin cancer heavy. And so some things you just can't do virtually as much as patients would like it, but still a good mix.
What is your cancer work?
I have an interest in skin cancer outcomes after chronic inflammatory conditions, particularly because in skin of color, we know that UV is not the major player. Chronic wounds, chronic inflammatory dermatoses may predispose to things like squamous cell carcinoma. So I have an interest in that. And so I'm sort of, with lots of balls in the air, leaning towards whether there can be some scholarly activity in that. And I'm also excited about some of the money that's come to U of T to fund some of these scholarly activities. So the next couple of years will be spent figuring out what's the why, and it may be what's the what as well too in some of these areas. So I'm interested in that. And I also want to thank you because a lot of the changes that have happened in dermatology in Toronto, as you know, is because you left a legacy of feeling safe and to ask questions and connecting with humor. And so it took a really long time for me to call you Neil. But in some ways, as you know, I think it's important. I think it's important to acknowledge that. And that's why I sort of started off by saying about the mentorship piece. So thanks.
Thank you. Thank you for saying that. Yeah, we had the speaker at the Canadian Derm one year about the future of dermatology. And she's actually based in Toronto, a PhD scientist in the area. It was it was a great presentation. But the one thing I remember that she said that just made me sit back and think, wow, was, and I don't know if she actually said this, but this is what I feel I heard, was get over the idea that you're going to miss a melanoma. All these things are going to happen, but, our argument is, if we don't see them, we'll miss them. Even though they're not being sent for melanoma, we'll miss it. Well, you don't look through everybody's toes to see if they have a melanoma. And the answer is, it was really liberating to hear that. I have to say that. And with COVID now, all the challenges there of getting people in and people sending you pictures that are terrible and just trying to, make sense of the whole thing. It is difficult. And the referral process is complicated. Despite all the dermatologists, I don't think we can handle all these patients. So there's so many, there's such a demand. But I'm very passionate and sensitive about the inclusivity area as well. And I think it's something, if you look at our program, I would say dermatology is an incredibly diverse training program. And I think that very much changed from an old boys club over time. And I think when people see that, when they see role models that reflect who they are, they say, oh, I can do that. That's open to me. And I'm really glad that we've been able to do that. I look at the faculty and the people who stayed on faculty and continue to commit in this area of next generation type of things. I used to tell the residents, I called it the magic. People would say, that patient you saw last month, you gave them this and they got better. Whatever made you think of giving them that? And I said, I have no idea. What? I said, I don't know, it just popped into my head. And I said, listen, I'll have the magic for a while. It takes about, maybe 5 to 10 years before you actually have the magic, but it'll go away one day. And that's when I quit. I quit active practice when it went away. I was like, I just asked the fellows, what do you think? It's like, okay, do what you think. Yeah, but the magic goes away. It eventually does, but it's a great experience. You just think, I think, what? I don't know why, but I think you should be on a statin or something. And it works. And whatever it is gets better. Now, there's also clues in the literature, and clinical trials are a rigged game as well, too. I mean, clinical trials just tell you that maybe a drug should be approved, but they don't tell you how to use it. They don't tell you what it is in different populations from age, skin color, et cetera. Okay, it was published. That's it. That's all it's telling me. There's nothing there. And how they became so dogmatic is really irritating to me, because it should not be just telling us which drugs we should get or how we should use them. All it's doing is saying, okay, we'll approve it for this, but you're going to learn things over the next 3 months that will say, yeah, this sucks, or no, here's other things we can do with it. And it is nice to see older therapies being repurposed in other indications, and that's really exploding too. I'm trying to keep up. It is challenging. I can't imagine it's a really big deal. So the trainees that you're working with, are you working with residents? Are you working with fellows and everybody?
Everybody. So we have medical students, residents, whether they're dermatology residents or non-dermatology residents. We have fellows. We actually have quite a few fellows that we work with as well, too. So sometimes it's fun to sort of see what everyone's different learning needs are. I always try to tease out two things people should remember about whatever topic we're talking about that's relevant to them in dermatology. And maybe it's because my experience of carrying that little notebook and not knowing what was going on for a little while. I can see sometimes, for example, a primary care trainee or a surgical trainee, their eyes sort of glaze over that what Latin name and what, this crazy case of ichthyosis, what do I need to know about that? But then distilling it down to some learning points. So that's always fun. But it's challenging. That, again, in terms of education, is keeping a whole bunch of balls in the air and then trying to create an environment that it's safe for them to ask questions.
I mean, what I think about what you're doing, though, that is really even more challenging is the balance of what's a dermatologic pediatrician or a pediatric dermatologist. And you fit both, but not many do. And so, when you have either group, so if you've got a pediatrician dermatologist or a dermatologic pediatrician, do they get the same teaching, I guess, and they work it out through their own filters?
They are decidedly different. I appreciate you saying that I'm sort of both. I wasn't always, though. It probably took about 3 to 4 years for me to comfortably say that I was both. And part of that is my pediatrics background allows me to feel comfortable in the space of children, their physiology, parents, and being actually comfortable pushing the envelope a little bit in terms of treatments and thinking about other soft things like their development and their feeding and all that sort of stuff, growth. And in some ways, I'm poised to think about multidisciplinary care. It sort of just is on the tip of my fingers. On the flip side, the diagnostics, I think, and the morphology from the dermatology side is another strength that is difficult to get outside of a dermatology training program, unless, again, it's like me, 3 to 4 years, you're out in the field. You're seeing a lot of pathology and describing and making these diagnoses. And so over time, you build up that side as well, too. And then the pathology and the surgical stuff as well. And that you just need hands-on experience and to be taught. And so my life as an adult dermatologist, I think, informs that, given the number of procedures I do and then the amount of path reports that, I have to read. So I think there's spaces for both versions of practicing pediatric dermatology. And there's a definite need, when we talk about adult dermatologists, one for every 55,000 Ontarians. I don't even know what the number would be for specialized pediatric dermatologic care. So it is very nuanced, I think, the difference between the two. And on either side, thinking about how you want to serve the patient population that we do, you could probably seek out specific training to address that. And I think it took me probably 3 years to get there because I didn't do a pediatric dermatology fellowship. I think the perfect sort of thing would be to do both and then go somewhere and do a peds derm fellowship, and maybe I'd get there a bit faster. But what I did was right out of the gate, just started working at Sick Kids, covering someone, and baptism by fire, which I think is what we do in a lot of ways in medicine.
It is interesting. I think about sick kids and how things change over time. When you come in the beginning, they say, oh, we don't have anybody like you. That's great. And somebody else comes like you and they go, yeah, but we already have somebody like that. Now you have to go do this. One thing I did see, of course, in terms of managing, patients and processes, the pediatric trained people were much better than us from perhaps in internal medicine or just from dermatology. They sort of knew different aspects of that part of the care. But moving forward, I assume there'll be a lot of changes in terms of what people are going to do, how they're going to network, what's going on in teaching pediatric dermatology after graduating from these specialties. Are you working on anything in particular that's going to enhance the, pediatric dermatologists, I'll call them that for the whole group, of the 2023 or something like that?
I think there's a collective move to find common ground and try to lay the framework for a body, particularly in Canada, because I think the Americans have sort of a framework and people who fit within that framework, because the models is much more common in the US to be double boarded, quite frankly. And so I think that's sort of moving towards that. But each institution across the country is so different in terms of the training background of the staff. And so I think it's sort of finding that commonality and what would even like a national sort of governing body, what direction would they take? And then I would say in the little micro sort of environment level at Sick Kids, we have different stakeholders with different backgrounds, whether it's peds derm fellowship for after dermatology or double boarded or pediatrics with a peds derm fellowship. And I think what we're trying to do is all sit at the table to determine, quite frankly, where some of the gaps are and how to address them with curriculum that evens the playing field. One trainee coming from a certain background, let's say a dermatology background, may need something else versus someone who's coming from a pediatrics background. So I would say these are all conversations, and I think important conversations. But with any conversation, I would say the why is just as important as the what. And so why are we doing it? It's because there's an unmet need. And what is that need? I would say most adult dermatologists treat children, right? As they should. And so the expectation, I think, for pediatric dermatology in that training is to provide advanced care and advanced nuanced care for whatever it is. If it's a little tiny patch of psoriasis on the back of the hand, I think an adult dermatologist has that. But if it's a child who's impacted by their quality of life, not able to go to school, requires systemic treatment, that's probably where a resource like a pediatric dermatologist is better served, given all the challenges we have with access to care.
I feel very inspired to hear about your vision of working as a group towards the future. Of course, it makes me think of an old song. But if you think of Fleetwood Mac, don't stop thinking about tomorrow. It'll soon be here and sooner than before, which is, of course, obvious. But thinking about today is irrelevant. Today's gone. And you can't stop thinking about tomorrow. It will soon be here. And it sounds like you're really working together with that as part of a community, which is great. And certainly is something, I think now with all the Zooming and everything, something we should be able to do in Canada as the numbers get more and we'll come up with our own model and local. I do, from what you were saying, made me think about people who are doing the wonderful work of being isolated in practice. Somebody somewhere, a very underserviced area, and there used to be none. We've worked hard over the years to get people to do it. They do enjoy it. They have a good quality of life. But I really feel, afraid for them should they get tough pediatric cases if they're not really trained in it. And I don't know how they manage it. I assume you must see some of these.
Yeah, I think that's where models like virtual care and collaborating, particularly if there's an expert on the other end of the line as well, too, can be very helpful. So hopefully we can expand those networks as well too.
Thank you so much for this. This is really terrific. And, your passion for all these areas, it's hard to imagine ahead of time. And when you think back, when you were in Nova Scotia, could you have ever thought you'd have this many balls in the air and so much at stake? But they start to fit together. They're all part of the same picture. What was monocolored before now is multicolored, and you're seeing all these different things happening at the same time. And your voice is being heard more. You have heroes, and I'll shout out Chronicle for doing it, but whether it's atopic dermatitis or skin of color or indigenous care, they're really stepping up to do what we would like to see happen for patients and making it better for people with skin disease in Canada, especially in role models maybe for elsewhere. So thanks again, Marissa. I really appreciate it. Thank you so much. You take care.
Thank you.
Thank you. Take care.
If you enjoyed this episode of Sheer Listening Pleasure, please do share it with your friends and colleagues. On our next episode, Neil will chat with another guest from the world of dermatology. To subscribe, go to www.derm.city or find the SLP podcast at Apple iTunes, Google Podcasts, Amazon Music, Stitcher, Spotify, or, really, wherever you get your podcasts. The producer is Jeremy Visser. Catherine Brendas provided research. Support for the SLP podcast was provided by Leo Pharma Canada. Send your comments to slp@chronicle.org. Until next time, be well.